Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, this is a great topic for you. Unintentional weight loss. I feel like in primary care you probably see this all the time.
A great topic in terms of that it comes up often, and I was happy to learn about it. It is often frustrating, so I was grateful to have some kind of framework to actually go through with it.
And we partnered with the Penn Geriatrics program. A lot of their fellows helped to write this, and one of their faculty, Dr. Eva Zemansky, was our expert on this episode. And Paul, to start off, I'll ask you, how do we define unintentional weight loss? Like, what amount of weight loss is significant?
Yeah, which it's important to define your terms, especially because I think this often comes in the context of coming from a family member who's concerned, and it might be a little bit tricky to quantify. But if we're being very specific, unintentional weight loss is defined as a greater than 5% loss in a 6 to 12 month period unintentionally. So if the patient's trying to do it, we don't get to count it. If it's happened over the span of 5 years, it doesn't quite cut muster. So it has to be in those 6 to 12 months greater than 5% without a clear reason why they're actually losing weight.
Yes, and we made the point on the episode, our guest made the point that failure to thrive, like just because they lost unintentionally 5% of their body weight, that doesn't mean failure to thrive. Failure to thrive is a geriatric syndrome. It's got to have multiple other things going on, like maybe they have weight loss and sarcopenia or frailty. It's more than just the weight loss. So don't just write failure to thrive in the chart if someone's lost a little bit of weight.
Yeah, I like that we got granular about it. So I think these terms are often used interchangeably. So failure to thrive is sort of a more syndromic picture. Cachexia is sort of wasting illness or wasting as a result of illness. And then sarcopenia specifically is loss of muscle mass. So like it's good to be super specific when we're talking about those things because it does help tailor your interventions and your work up to some extent.
And Paul, we put this into the 5 M's framework. It's a mnemonic. It's just a simple way to sort of stay organized when you're working up these geriatric syndromes, which are kind of multi-complex, multi-system problems. Like someone's falling. It's usually not just like they're walking around with their shoes untied. Like there's multiple things going on that are causing them to fall, and unintentional weight loss is usually a geriatric syndrome. So let's put in the 5 M's framework. Paul, what are some of the 5 M's?
So the 5 M's are mentation. So are there mood issues? Is there cognitive impairment? Are they depressed? That kind of stuff. Medications are our bread and butter, our favorite. We talked a lot about deprescribing on this exercise and how we love it. Mobility, how active are they? Can they get around? Can they perform their ADLs? What matters? So a little bit imperfect, but still there's an M in there. So what do they value? What makes them happy? And then multimorbidity. What else is going on with them? What other illnesses may be contributing towards whatever syndrome we're talking about?
Perfect. And Paul, so the steps, you're going to go through the 5 M's when you're talking to somebody about their unintentional weight loss. Often it's going to be a patient. Maybe they'll have a family member there as well that's kind of providing extra information. But Paul, like starting with this, she mentioned that this can take a long time to go through. In a visit, if you have 15 minutes just to go through all the meds and all the supplements or other substances they're taking, that might take your whole visit right there. So she mentioned that you might see this person over time, and you might not be able to hit every single M in one visit, but you should try to get to them all over the course of your workup.
And luckily, most of the time, this weight loss is happening relatively gradually. Like this is not something that happens between 2 visits, so you have time to kind of work on this longitudinally.
Yeah. So I think a good place to start is often like screening, like, is this person depressed? Is that why they're not eating? Are they having memory issues? Because there can be a lot of issues with memory, like maybe they're forgetting how to fix meals. They're not remembering if they've eaten or not. There's a whole bunch of ways that memory can be involved. Step 2, Paul, the medication list. Any common meds that cause problems here?
I mean, almost all of them is the issue. I mean, like I think we talked about some of the medications in the beers list, and you often, if you live long enough, you accumulate medications, then treat the side effects of those medications with other medications, and treat the side effects of those medications, and so on and on. So like it's not unusual to have lots of anticholinergic medications that cause dry mouth, or that may cause nausea, or may cause constipation. Some of the medications that we even use to treat dementia commonly have GI symptoms that come along with them. So there's lots and lots of medications. Your antihypertensives classically cause all kinds of side effects that may make eating less appealing. So really take a good hard look at the medication list and see what absolutely has to be there, because you may be able to prescribe, and that may help their appetite a great deal.
I had a guy in my office within the past couple months. He was a geriatric patient, losing weight. We ran his med list. He was taking metformin, even though his A1C was like 5.8.
Yeah.
He was having a little bit of stomach upset, and he was on iron for some reason. I had not prescribed him iron, and I could not figure out why he was on iron. We stopped both those. It's not like his A1C came up a little bit, but not too much, and he's eating better now. Family's happy, so it can be that easy sometimes.
Yeah,
Um,
for sure.
you will probably want to do a limited evaluation, like lab wise. For the labs we talked about was pretty minimalist, like CBC, a comprehensive metabolic panel, TSH. You might check for some chronic viral illnesses like HIV or hepatitis. Checking for B12 can kind of give you a sense, like, is that impairing their cognition a little bit, but also are they having malabsorption of some sort? And limited imaging evaluation. Paul, do you order many images for this?
It really truly a case by case basis. We talk in the episode. Oftentimes that imaging has been done for you. If someone's had a
Yeah.
fall, they've been through the donut of truth. You can probably go back through the ER notes and look at the trauma CT scan. There's almost everyone's had a chest X-ray at some point. We talked about, I think some of the guidelines or one of the papers recommends doing abdominal ultrasound as part of the evaluation, which is probably recommended at a time when CT scans were not as quite as readily available as they
Yeah.
are now. So if depending on how aggressive the patient and the family want to be and sort of what's already been done, I may do cross-sectional imaging, but certainly not every time. And oftentimes that data is available there for you already.
And finally, I think a lot of the time you're not going to find one specific thing that is causing the weight loss. Especially on that diagnostic workup, it's mostly to make sure you're not missing anything like glaringly obvious. A lot of the time, you're not going to find much. So we talked about, like, if you do find a cause, sure, treat that. If you don't, liberalizing the diet is a good way to go. So kind of highly palatable foods that the patient will eat. If they become a picky eater, just try to keep their favorites on hand. Give them more time to eat. Make sure that things are pretty simple. So if they have dementia, some patients get confused if the place settings are too complicated. Anything else, Paul, that we're to point out?
I appreciated the emphasis on making eating a social experience too. That really can make a difference. I've seen it work in the past, so it's just a really important thing that I was glad that we took the time to talk about.
Right. So, I mean, and this is something where you're going to you make some of these changes, follow the people over time, see if it gets better. I guess one other thing we haven't mentioned, I have had a couple patients, Paul, where they had loss of taste and smell for various reasons, whether it was a viral illness or whatnot, but that was the main contributing factor. And so that can be another thing just to look out for. But I mean, this is a common condition. You're definitely going to see it. If you stay organized, use the 5 M's, follow some of the steps we talked about, you should be able to give a pretty good answer and work towards correcting the problem, stopping the weight loss. So with all that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Still gross after all these years. And I remain Dr. Paul Nelson Williams. Thank you and goodbye.